Good afternoon, everyone. I'm Nirav Shah, the director of Maine's Center for Disease Control and Prevention. I'm delighted to be able to join everyone this afternoon to provide you all an update on where we stand with respect to COVID-19 across the state of Maine for today, Friday, December 18th, 2020. And I begin this afternoon's update on another set of sad notes. Maine CDC has received reports of 5 individuals who have died with COVID-19. One of those individuals passed away yesterday. 4 of the individuals passed away in recent days. 3 of the deaths were all among men in their 70s from Kennebec County. Another death was in a woman in her 80s from York County, and the last death was in a man in his 80s from Kennebec County. Their passings mark the 279th, 280th, and 281st deaths among people with COVID-19 in Maine. I'd like to take a moment to offer our deepest condolences to the friends, family members, and communities of all of these 5 individuals, as well as collectively all 281 people who have lost their lives to COVID-19 in Maine. Overall, across the state, there are now a total of 18,337 individuals with COVID-19, an increase of 436 cases since yesterday. Of those, 15,942 are confirmed cases, 2,395 are probable cases. Since we began working on COVID-19, since the pandemic started, 965 individuals have been hospitalized. Just in the past 30 days alone, 319 people have been hospitalized in Maine with COVID-19. And at this very moment, 177 people are currently hospitalized in Maine. 46 of those folks are in the ICU and 15 are on a ventilator. Among our 18,000 plus cases, 2,097 are among healthcare workers. And as I mentioned a moment ago, sadly, there have been cumulatively 281 deaths associated with COVID-19 in Maine. I'd like to take a second now to turn to some outbreaks that Maine CDC has opened in recent days. The first is at the Biddeford Middle School. Another outbreak that we have opened is at Eastern Maine Medical Center. A third is at Freightliner of Maine in Westbrook. Another at the Mountain View Correctional Facility. Also, we've opened an outbreak at the Pine Point Center in Scarborough. And finally, we've opened an outbreak investigation at Woodland Pulp. We've also, just this morning, those are investigations that we've opened yesterday. This morning, we opened investigations into an outbreak at the Maine Veterans Home in Scarborough, where we are aware of 3 cases, at Sacapee Valley Middle School, where we are aware of 5 cases, and at the Waynfleet Upper School in Portland, where we are aware of 4 cases. Also, in the past 48 hours since I last spoke with you, Maine CDC has reopened 5 outbreak investigations, all 5 of which happen to be in school settings. The reopened outbreak investigations are at the Lewiston High School, at Lewiston Middle School, at Paris Elementary School, and at York High School. Now, I'd like to pause for a moment to talk about these outbreaks in schools, because on first blush, it appears that the number of outbreaks in schools is overwhelming. But some of that is a function of how we define an outbreak investigation. We open an investigation when we have reason to believe that there are 3 or more epidemiologically linked cases of COVID-19 in a setting. Even though we may be opening an investigation in schools, thus far, at this point in the school year, we have thankfully seen very limited transmission within schools. I talked about this a few weeks ago, and thankfully that finding seems to have held, not just in Maine, but across the country, owing to the amazing and dedicated work of teachers, faculty, staff members at school, as well as students and their parents, by doing things like keeping classrooms spaced apart, by wearing masks, by putting up plexiglass in places to block the transmission of the virus. Although we may be opening investigations into schools, in most instances, those investigations and the cases that lead to them are a direct link, are directly connected to community levels of transmission, not because of transmission within the schools themselves. Now, that could change. If rates of community transmission become high enough, and there are a high number of students or faculty members or staff within a school who are positive at one time, the possibility of transmission is something that could occur. We are on the lookout for it. But as of right now, thankfully, that degree of transmission in schools has been limited. Turning next, and just to be really clear, that is not an accident. That is because of the hard work and dedication of teachers, staff members, students, and their families to keep schools open and to keep them safe. And so I'd like to take a second to thank them for those extraordinary efforts this year. If you go back several months, there was a high degree of concern over the possibility, the risk of transmission in schools. Thankfully, nationwide as well as in Maine, that has been limited owing to their good work. Thank you. I'd like to turn now to where we are with respect to testing. Right now in Maine, the 7-day PCR positivity rate stands at 4.43%. And our PCR testing volume stands at 563 PCR tests that are being done for every 100,000 individuals. Our antigen positivity rates are somewhat similar. The 7-day antigen positivity rate now stands at 4.9%, and the antigen testing volume, which is lower, stands at 151 antigen tests for every 100,000 individuals. Now let's turn now to vaccinations. As of yesterday, there were a cumulative now 2,264 people across the state of Maine who have received their first dose of the COVID-19 vaccine. Again, that's 2,264 people who have received their first dose of the COVID-19 vaccine. As per our approach, those individuals are predominantly frontline healthcare workers, individuals who, as part of their duties, taking care of all of us, come into contact with the COVID-19 virus at higher rates than others. These are folks like emergency department staff, ICU staff, individuals who work, say, in congregate living settings like nursing homes. That's who is right now receiving the vaccine. Speaking of individuals who live in congregate living settings like nursing homes or who work in them, starting this Monday, a program that is being orchestrated in conjunction with the US CDC, with retail pharmacies, and long-term care facilities themselves will be starting off with the first vaccination events happening at certain skilled nursing facilities across the state starting this upcoming Monday. I'd also like to take a second to talk about where we stand with respect to vaccination efforts as a country, as well as to answer one or two questions that have come in. Let's first start with where things stand at the national level. Yesterday, an advisory committee comprising independent scientists who are experts in vaccines met to discuss the latest data on the Moderna vaccine. These scientists reviewed both the safety as well as the efficacy of Moderna's vaccine candidate, and after that review, recommended that the commissioner of the US FDA grant an emergency use authorization for that Moderna vaccine. If history is any guide, that emergency use authorization, if the commissioner of the FDA agrees, could come anytime in the next few days. If that were to happen, there's another step, which is a separate panel of scientists who advise the US CDC, who are scheduled to meet this Saturday and Sunday to similarly review the clinical and scientific data underscoring the Moderna vaccine and make recommendations on how and in whom it should be best used. If all of those pieces fall into place, there is the possibility that Moderna vaccine could be arriving in Maine as soon as early next week. Also here in Maine, we have just today indicated to Operation Warp Speed where we would like the second round of our allotment of Pfizer vaccines to be distributed. Those Pfizer vaccines could be distributed in Maine by Operation Warp Speed as soon as, again, early next week. Recently, however, Operation Warp Speed informed the state of Maine that with respect to the Pfizer vaccine, Maine would be receiving less than they initially projected that we would receive. This is unfortunately a finding that occurred in a number of other states as well. Initially, Operation Warp Speed suggested to us, estimated to us, that the state of Maine would receive 13,650 doses of the Pfizer vaccine in this second allocation. A few days ago, we learned that that estimate had been lowered significantly from 13,650 down to 8,775, a reduction of 4,875 initial doses. That sadly and regrettably had implications for us. As a result of the reduction by Operation Warp Speed in the allocation for the state of Maine, the state had to opt not to activate another phase of the pharmacy partnership that I talked about a moment ago. To recap, the pharmacy partnership is a process that has been led by and orchestrated by the US CDC, working with certain retail pharmacies and long-term care facilities. The part which begins on Monday focuses on skilled nursing facilities. Part B, which was to begin the subsequent week, focused on other long-term care facilities like assisted living. Because of the reduction from Operation Warp Speed in the number of Pfizer vaccines that Maine would be receiving, we did not have physically enough of the Pfizer vaccine available to us to begin activating that second part of this partnership. Unfortunately, that part may have to wait till the subsequent week. That is unfortunate and regrettable. As soon as we know more information as to why this reduction happened and whether it will be good, we'll make sure we keep everyone posted. And finally, one note about some pharmacists across the country have been administering the Pfizer vaccine. Some pharmacists noted that the vial that the Pfizer vaccine contained more than the 5 doses that it was indicated to contain. Those pharmacists raised this finding to the US FDA and the US CDC to determine whether it would be safe to use what's called this overfill amount. The FDA and the CDC took a look at it and authorized, they okayed the process of using this extra vaccine in the vials to vaccinate more and more people. As a result of that, virtually every one of the current Pfizer vials has at least an extra dose. That's 20% more that can be used per vial as a result of this overfill. The bottom line here is that this is a splendid holiday gift. Let's hope it stays that way. Before I turn to questions from the media, I wanted to continue an occasional series as part of our efforts to provide clear, open, scientifically accurate information about where we stand with respect to the COVID-19 vaccine. And since I started doing this on Wednesday, I asked for questions to be submitted. And overwhelmingly, the number one question that was submitted to us through different channels was this: are these vaccines being rushed? I want to take a moment today to talk about this question and give everyone my honest appraisal of that. Let me start by observing one thing. The development of these vaccines, be it the Pfizer vaccine or the candidate from Moderna, was undoubtedly accelerated. But that should not be taken to mean that the development was rushed. Both vaccine candidates went through the normal, rigorous phase 1, phase 2, and phase 3 clinical trial processes. No corners were cut. It's also important when you're thinking about this to think about the context. Even though these vaccines may be new, the technology that underlies them, this mRNA technology that we talked about on Wednesday, is not new. Indeed, it's been scientifically developed and honed and refined over nearly 3 decades. This technology, using what is a molecule called mRNA, represents the scaffolding underneath these vaccines. And again, this technology has been used and tested to make vaccine candidates for other diseases, like, for example, rabies and Zika virus. Once you have that scaffolding in place, building the actual vaccine around it is more straightforward. That is to say, once you know how to build a type of vaccine, you can accelerate building the actual vaccine. It's the difference between building a house with blueprints versus building the house with no blueprints at all. The other thing to keep in mind as we're thinking about this question of whether these vaccines were rushed is to keep in mind that we are already used to vaccines being developed in less than a year. Take, for example, the flu shot. Every year, we build a new flu shot that is different in composition from the flu shot from last year. But it's not a new vaccine. It takes a blueprint from existing vaccines and then rebuilds it with a few modifications. That is similar to what's happened with these vaccines. They took the blueprint from other candidates that have been studied and adapted it for COVID-19. But it still leaves open the question, how specifically did they accelerate this process so much? Well, there are a couple of reasons and ways that the system was accelerated. The first is, let's start with the money. There were billions upon billions of dollars in funding, both public and private, that were directed to make COVID vaccines a top priority. It was also a merging of interests. It was in everyone's interest to get a vaccine developed as quickly as possible, given the severity of the pandemic right now. The thing is, often in clinical research, there's a lot of hurry up and wait. You hurry up and wait for your funding. You hurry up and wait for your paperwork. You hurry up and wait for the regulatory sign off. But each of those things can be accelerated if there is a will to do so, if we all collectively agree that the vaccine at issue is the top priority, which everyone in the world did agree to. As a result of that, all of those things that typically involve hurrying up and then waiting for periods of time were accelerated. It was like traveling down the road with nothing but a string of green lights in front of you. Once that clear regulatory pathway was erected, that meant that COVID-19 vaccine development could be rocketed to the top of FDA's review process, a process that doesn't usually even get initiated by FDA for 6, if not 10 months, could be initiated because we agreed that this was the top priority. There's another factor that differentiates COVID vaccine from other vaccines, and that is, sadly, just how prevalent the disease is. The trials around this vaccine in particular, these vaccines, were keyed to look for a certain number of individuals who had tested positive. And those are called event-driven trials. Event-driven trials enroll people until they've reached a certain number of positive events. In this case, a number of people that have tested positive for COVID. When you have an event-driven trial, the more common the thing you are studying is, like COVID, the quicker you can move through that trial. Imagine if you were trying to develop 2 vaccines, one for COVID, something that is all around us with tens of thousands of cases, and another for rabies. If you wanted to try to get enough people into, or enough animals into a rabies vaccine or rabies trial, we'll stick with humans for right now, you would have to potentially have that trial going on for years and years and years to accrue enough infections to determine whether you are actually seeing a difference with your vaccine. But with COVID being as prevalent, sadly, as it is, you can move through that process more quickly. Indeed, in this situation, as the clinical trials were being enrolled, COVID was on the rise, which meant that they could speed through the trials that much more quickly because there were, sadly speaking, a higher and higher number of cases of COVID, which allowed for more quick detection of whether the vaccine was making a difference. Now, let me end with this. It's natural to ask whether a brand new vaccine with a new technology for a disease that all causes us great anxiety was being rushed. That is a legitimate, natural question. As I've said previously, we respect those questions and we welcome them. It is our job to give you straight, honest, transparent answers to those completely legitimate questions. In this situation, though, it's also important to keep in mind that thousands of scientists from around the world have worked on these vaccines. Dozens of career scientists at the US FDA reviewed the data from the pharmaceutical companies to see whether their conclusions matched with their numbers. 2 independent committees of scientific experts who have no affiliation with either the companies or the US government have independently reviewed the data, to say nothing of independent scientists in the UK, Canada, and very soon in the EU. Based on everything we know right now, these vaccines were definitely accelerated because of the pressing public health need posed by the pandemic. But in my view, they were not rushed and no corners were cut. And that is why, to this day, when my number is called, when my place in line is up for the vaccine, I will take it. So with that, I'm going to turn things over to our colleagues in the media. The first question for the afternoon today goes to Patrick Whittle.
Thank you very much. Nice to be at the front of the line. So you addressed numerous of my questions in your monologue, but one thing I wanted to make sure I have my mind around here, the Pfizer vaccine is a 2-dose series, but the numbers in the 2 shipments were different numbers. So those are all different first doses for different people. Those are not a pairing. Is that a fair thing to say?
You are correct, Patrick. What we have been told by Operation Warp Speed is that these allocations represent the first dose, but that we do not need to, within our state's allocation, reserve the second dose. What we have been told by Operation Warp Speed is that those second doses are being held in reserve for us. They will be delivered in a timely fashion when it is time for those second doses, but we need not account for that in our planning. That's what's been represented to us.
Got it. And you mentioned one of the ramifications of this delay. Is there a possibility of sort of like sort of a cascade of events where this results in the statewide distribution being sort of pushed back to a later time, or are we at too early of a stage where we could foresee that?
It's a bit too early to know for sure. We are right now hoping for more stability in the estimates that we receive so we can engage in that longer horizon planning. Right now, what we've been getting is an estimated allocation on Tuesday or Wednesday, and then having to put in an order in quotes against that a couple of days later on Friday. We're hoping that in the coming days, if not weeks, we'll see more stability in what we can expect for weeks 4, 5, 6, et cetera. And then we'll know whether there are these ripple effects. Right now, the most immediate one is the one I mentioned. If that were to persist, it's possible, Patrick, that there would be further going ripple effects, though.
Okay. And one last thing, there's a fairly well publicized story of a healthcare worker in Alaska who suffered a pretty serious sounding reaction to the first dose of the vaccine. What can the state of Maine do to sort of educate people about those kind of events and what to look out for and the likelihood that they could occur?
Sure. Well, one thing that I'll be doing probably on Monday is talking about those events a bit more. But in the interim, what I want everyone to know is that, as Patrick mentioned, there was an unfortunate incident of a healthcare worker in Alaska who had a reaction to the vaccine that they were administered. I believe it was on Tuesday, perhaps Wednesday. Um, and although that was troubling, it raises anxiety. It's also important to note that now worldwide, as the Pfizer vaccine has been rolled out, there have been three such events. All three such events were within healthcare systems. The exact protocols were followed, meaning individuals were asked to wait a number of minutes after their vaccine to observe for such events. When they were spotted as occurring, proper measures were taken, meaning epinephrine and other emergency protocols, and they were immediately reported both to the US CDC as well as to the state health department. I've exchanged some messages with my counterpart in Alaska who reports that the system worked as the system did, or the system worked as the system was supposed to. Anytime we are engaging in such a massive worldwide effort to vaccinate individuals, there will unfortunately be some adverse reactions. None of them was detected in the clinical trials, thankfully, so we believe that they will be rare, but they are a possibility. In this situation, it once again comes down to whether the very small risk of an adverse reaction is the thing to worry about, or whether COVID is the thing to worry about. Given what we know about COVID and how quickly it's expanding across the country and in Maine, to me, that's the risk to worry about. I'm
Okay,
going to
thank
turn it
you.
over to Amy Brown next.
Thank you, Dr. Shah. Can you say more about the outbreak at EMMC?
We're still gathering information. One of our medical officers who works specifically on hospital-related outbreaks was having a series of calls with them. I believe the hospital itself was putting out information about that. And so I don't have anything further at this time, Amy, but I would refer you to EMMC. I believe that they've got some information to put out with respect to the latest on case counts.
Okay, and a quick follow-up, that count of 2,264 people vaccinated so far, that was as of this morning or now, or?
That was a good, thanks for clarifying that. That was as of this morning. That number has invariably gone up just over the course of today. Hospital systems across Maine have now been reporting to us that they are able to vaccinate several hundred of their frontline staff every day. So that number was as of 8:30, 8:15 a.m. this morning. And so it has almost certainly gone up by several hundred.
Okay, great. And then finally, it seems like the positivity rate stayed steady for a while, and now it even seems like it's dropping. What do you make of that? Is that perhaps more people who are well and don't feel like they've been exposed getting tested for travel and skewing that number a little bit, or?
Great question. I don't have a good theory, to be honest with you. My team has been looking at that ourselves. The thing is, positivity rate means different things based on where you are in a pandemic. Initially, the positivity rate was a proxy for testing capacity, how much testing could occur. In other phases of a pandemic, it's a good proxy for the prevalence, just how much disease there is out there. So I don't. I'll be completely straight with you, Amy. It is subject to different interpretations. One interpretation is that there's a lower baseline level of disease, and more people are getting tested. Although the testing volumes have similarly been holding steady. There's not one clear interpretation or one clear story that emerges from the positivity rate. The number that I will say that I look to just as much as the positivity rate these days is the hospitalization rate. And there's also been a little bit of a decline, but still worryingly high.
Thank you.
Mm-hmm. I'm going to turn next over to Dustin from New England Cable News.
Hi, Dr. Shah. I know you sort of touched on this, but what's the tangible impact of the smaller Pfizer allocation? And what I mean by that is, who exactly is going to be waiting for doses, and what additional risks do they face while they wait?
As a result of Operation Warp Speed reducing the allocation to the state of Maine, as well as a number of states. I don't mean to suggest this was a Maine specific or even a New England specific reduction. From what I understand from my counterparts, this was an across the board reduction. As a result of that, Justin, Maine, we do not have enough allocation of our Pfizer vaccine to meet the 50% threshold to activate Part B of the pharmacy partnership. Let me unpack that. In order for a state to activate this pharmacy partnership, Part A being skilled nursing, that is proceeding untouched. Part B being assisted living and other such long-term care facilities. In order for a state to activate that, we have to commit to setting aside at least 50% of the total that would be needed for that part in the first week, 25% in the second week, 25% in the third week. Because of this reduction, we did not have, just mathematically, enough to meet that 50% commitment. So we are hoping that the subsequent week, we will be able to activate it, although I can't promise that because we have not been given an estimate for that subsequent week. As a result of the reduction by Operation Warp Speed, we are delaying that start, which means that, for example, some individuals and staff who live in assisted living and other long-term care facilities may not start their vaccine clinics for another week.
And then the second question is there any way to make up for this allocation with the Moderna vaccine or something else?
One of the rules of the partnership is that when a state opts in, they have to commit to using one or the other of the vaccines. And that's for operational purposes because the vaccines have such different handling and storage and administration requirements. We, as well as I think most states, utilize the Pfizer vaccine because that was the first one we got. We didn't want to put a bet on Moderna getting approved or not getting approved and having to wait even longer. So virtually all the states that I know of, maybe save for one or two, opted to start with the Pfizer, and thus we can't swap out. I'm going to turn next to Emily Tadlock at WABI.
Hi, Dr. Shah. So my first question is about EMMC and the outbreak there. Hospitals are supposed to be among our safest places, the places where we have the most PPE, the places where we know that our medical professionals know how to use these things and know how to be safe and are requiring people to come in with masks and people to take their temperatures. How is it possible that an outbreak like this can still happen?
Sure. Well, Emily, let me first note that we have been working with hospitals to keep hospitals safe from COVID since well before we even had our first case in Maine. I think the fact that we have seen outbreaks in hospitals is evidence of just how aggressive the COVID-19 virus can be. The fact that in controlled settings where, as you note, PPE is the norm amongst everyone who is in there, face coverings are the norm. The fact that there could be transmission events within the walls of a hospital is further evidence of just how aggressive this virus is. I don't mean to suggest for a second that because there was an outbreak somewhere, there was necessarily any kind of lapse. Oftentimes what we see is outbreaks in hospitals being a function of community transmission and individuals congregating outside of work, for example, possibly spreading the virus and then coming into the hospital because they work in a hospital, getting detected. I don't know if that's the situation with EMMC. Again, our medical officers and epidemiologists are working with them right now to get a better sense, but outbreaks in hospitals are a risk. It is one reason why among the top priorities in Maine and across the country to vaccinate folks against COVID-19 was healthcare providers. Because if hospitals start going offline because they are experiencing outbreaks and staff outs, the ripple effects there will reverberate far wider.
Okay, and then one of those ripple effects as you're talking about is actually I'm hearing from several nurses that there really is a hospital bed shortage in the state, especially for rural hospitals. They're really struggling, not just for COVID patients, but for patients in general, people who come in with heart attacks or just need to be in the hospital for a few days. I'm hearing that there really is a shortage in beds, and with outbreaks at hospitals happening like this could be an even bigger problem going forward.
Absolutely. And I've kept in touch with a few of the CEOs of rural hospitals, I've kept in touch just recently, and I try to ping from time to time the CEO of Holton Regional Hospital and Cary Medical Center to see what their bed counts are looking like, and whether they are stretched thin, and where they are at. That is a concern. Now, what has happened more recently with respect to COVID is that because hospitals have the ability to take care of COVID patients in the community, as opposed to needing to transfer them to Bangor or Portland, community level hospitals have been great at keeping folks close to home. But as those hospitals get stretched thin, there is the possibility that folks may be transferred elsewhere. In the winter, that poses challenges, to say nothing of the fact that they're even further away from their family. So this is yet another example why COVID is a different disease than what it was earlier. Earlier in the pandemic, it was a predominantly urban phenomenon. But now, as it has moved into rural parts of the states, the hospitals in those states are not immune to it either. And the staffing shortages and the bed shortages that you mentioned are an absolute concern.
Thank you.
I'm going to turn next to Evan Pop.
Hi, Dr. Shah. Thank you. I'm wondering, since vaccines are being distributed through hospitals, whether or not hospitals are allowed to prioritize healthcare workers at their own affiliates, such as labs, clinics, and long-term care facilities, over competing agencies that might not be tied to a hospital's network.
That's really more of a question for the hospitals themselves. What we have recommended hospitals do is administer vaccine to healthcare providers writ large who could potentially be coming into contact with patients or infectious materials, and cast the widest net possible with the doses that they are allocated, using risk of exposure as the guiding principle. Different hospitals may opt to do that in different ways, and trying to sort of prescribe exactly who should happen on Thursday versus Friday versus Saturday morning. That's not something we've got as much insight to. So we relied on the ground level experience of hospitals to determine the best way to make those decisions.
Great. And my second question, I was just wondering if you could give a sense of when healthcare workers who work at family planning clinics and organizations can expect to receive a COVID-19 vaccine. Would they be in that kind of latter part of phase 1A that you've talked about after the initial people in phase 1A?
So the timeline there, Evan, depends on the supply of vaccines that we get. But directionally speaking, yes, they would be at the latter phases of 1A. But when that starts to happen is difficult to predict. And again, it really does depend on what their risk of exposure is. That's going to be the guiding principle that we use, not just with respect to, say, healthcare providers, but others as well. And so as we move into the latter portions of phase 1A, we'll be working with, for example, federally qualified health centers and other such places to vaccinate their staff, outpatient providers, things of that sort. But when we get there is a direct function of how much vaccine we receive. The news from Operation Warp Speed this week that our allocation was cut, unfortunately, stretches that out even further. I'm going to turn now to Patty White.
Thank you, Dr. Shah. First, I just want to make sure I understand this 40% decrease. Is that expected for both next week, week 2, and for week 3?
Patty, we have not been told what our allocation for week 3 is for Pfizer vaccine.
Okay.
So I don't know. I can't say. We have not received a locked number as to what our week 3 Pfizer allocation will be.
Okay. And then I wanted to ask you a math question. I apologize in advance for throwing what sounds like a word problem at you on a Friday afternoon. But given that the Pfizer vials have about 20% more than expected, if that continues, I mean, how much does that offset the 40% reduction that we're getting in our allocation? Does that kind of help make up for that?
Yes, no, it doesn't. Unfortunately, that's the bottom line. So we've kind of looked at that as well, because that was an initial glimmer of hope. And it does help. I don't want to discount this, again, splendid holiday news that we've received, that there was this overfill, kind of like a heavy pour into the vials. That's good news, but it does not erase the fact that our overall allocation for the subsequent week got cut, especially because one of the things that was intended to be used for that next week of Pfizer was for the set aside to start Part B of the vaccine clinic. The doses just aren't fungible in that way. So while we're delighted to see that there's 20% more in the vials, it doesn't make up for the 40% reduction that we got. We're still 20% down.
Okay, thank you.
I'm going to turn now to Don Kerrigan at News Center. It's been a minute, Don.
Hi, Dr. Shah. Good to talk to you again. I have start off with a question, one more about this reduction in the allocation of vaccine. Does the fact that you can't seem to get an explanation from the Operation Warp Speed folks give you any less confidence in their ability to manage this whole distribution thing?
It's hard to say, Don, to be candid with you. It's certainly, the news itself was disappointing, but we are in forward going mode, right? We're literally and figuratively plowing ahead. And we have reached out, for example, to our congressional delegation and their teams to help us navigate this and try to get more direct answers. In fact, this evening, I have the privilege of being on a call with one of the principals at the US CDC, where I intend to put this question directly to them as well. And I've asked my team to put the question directly to Operation Warp Speed. We're hoping to get clarity, partly for confidence reasons, Don, but also for planning purposes. We'd like to know if there are these types of expected shifts to be coming, these crests and peaks and valleys in the allocation. That takes us down one set of planning. But if they've achieved stability with respect to what they think we will get on a week-to-week basis, that takes us down another pathway. Suffice to say, it's frustrating, but we are in, we're looking out of the windshield, not the rearview mirror at this point.
And two questions about the MMC situation. One very brief. I was dealing with a technical issue. So if you said the actual number in the outbreak at EMMC, I didn't get that. What is that number?
I don't have the precise number, Don. I know, again, our medical officers were speaking with the leadership and the infection control team at EMMC to determine what the exact number associated with this outbreak is, as opposed to unassociated with the outbreak. I don't have that exact number right now. I believe that EMMC may be putting that out. If I'm wrong on that, then I'm wrong on that, and we can get you the number once our teams have had a chance to connect. This news about the opening of the outbreak at EMMC is just a handful of hours old, and it's that trade-off between wanting to be upfront and direct and timely and transparent when I report these things, but not necessarily having every detail be straight with you. So if EMMC has not put that number out, once our teams have had a chance to connect, we'll try to get it to you and others.
Okay. So then, and this is following up on a question asked earlier about that. If workers at the hospitals wear with N95 masks, all of this other stuff, can get this, what's that say to everyone else? And is it who's out there wearing cloth masks, which offer far less protection? Should they be worried every time they take a breath?
The answer is no, they shouldn't. And the reason, Don, is that there is an assumption in your question that I respectfully disagree with, because I don't know if it's true or not. And the assumption in your question is that there was transmission that occurred while staff members and patients were fully garbed in the PPE. while staff members had on their N95 masks, while patients had on their surgical masks, there was an assumption in the question that transmission occurred notwithstanding that wearing of PPE. And I don't know if that's true. So one of the questions that our teams ask is, how rigorous was PPE being used? Was it possible, for example, that staff members were congregating outside of the hospital without wearing their masks and PPE because they were hanging out together or had dinner together, and thus may have transmitted it that way? So I don't want to suggest that the PPE was at fault, or that PPE, to say nothing of cloth-based coverings, is not doing a good job. We know over and over again that the science is settled on N95s being wonderful barriers of source protection, as well as cloth-based coverings, reducing the likelihood of community transmission. The science is well settled on that. We just need to uncover more facts to be able to speak more about the question you noted, Don. I'm going to turn now to Caitlin Andrews at the BDN.
Good afternoon, Dr. Shah. Can you hear me okay?
I can, Caitlin, go ahead.
Perfect. So first thing, I just had like a clarification question. The press release mentioned that the vaccinations for the other long-term care facilities would have to start after the December 28th. And I think you said like that they would probably be delayed by a week. So is that correct? Those will now be starting like the first week of January?
Excuse me, Caitlin, that is the hope. We will need to see what the week 3 Pfizer allocation will be before we can officially activate that piece of it. But the hope would be that they start not on the week of the 28th, which was our initial desire, but perhaps the subsequent week.
Okay. And this is kind of like a far away theoretical question, but you know, in a world where the vaccine becomes more open to the public, I'm curious to know what you would like to see happen when it's more widespread, and how public should kind of treat people when they're vaccinated, i.e. like, do you think that it should be a requirement for public schools or for people to enter public places? You know, what are your thoughts on that?
Yeah, I in a world where vaccine is widespread and we do not have the supply constraint that we do right now, my first hope would be that uptake of the vaccine was robust. You know, there are different epidemiological models that predict just what percentage of a population needs to be vaccinated in order for us to achieve that bubble of immunity that we're hoping for. And those numbers vary from anywhere from 65 up to 80%. So my first hope would be that we get to those numbers. We get in Maine as close to the highest threshold we can. We should be aiming for 80%, if not higher in Maine. But to the specific questions you raised, Caitlin, about policies that might be put into place, I don't know that anyone has really thought those through. I've got different ideas about them because there is a certain, given that folks are hesitant, I think we've got to get them over their fears and answer their questions first to make sure that we are bringing people along. That's the first best goal. If that doesn't work, then we have to think about others. But I don't think I've really sorted through what the implications of, say, mandates around these things would be, so on and so forth. I know those discussions are out there. I suspect that we will be having them as a state and as a country much more in the future, but I don't have a firm position on them yet. I think my goal would be to encourage folks through every means possible to seek the vaccine because of the data that we've seen and the benefit the vaccine has for everyone.
Thank you.
I'm going to turn to Mal Meyer at WGME next.
Good afternoon, doctor. Thanks so much for taking my question. Has the Maine CDC, have you guys been in contacted with the assisted living homes with this update, and how have they been responding to it from the delay?
Yep, we have let them know, I believe yesterday morning. We let the leadership of the Association of Long-Term Care Facilities in Maine know about this change from Operation Warp Speed that prompted this. And then I believe on a call yesterday morning with more of the stakeholders themselves. I think I was not on that call, to be candid, Mal, so I can't speak firsthand about what the reaction was. But from what I was briefed out on, they were, I think they understood that this was a change that was given to us by Operation Warp Speed. And mathematically, there was not a way we could, per the terms of the CDC's partnership agreement, there was not a way we could meet that minimum threshold of 50% in the first week. And that's just unfortunate. And we of course are disappointed, and we wish it didn't have to be this way. But we're hoping to get more clear answers from Operation Warp Speed as to why this change was made, so we can improve our planning going forward.
My other question is real quick. You noted that the next vaccines are supposed to come in early next week. Do you have an exact day of when that's anticipated?
We do not know. We usually, at least usually, we've only received one shipment. But as to the first shipment we received, when the vaccines were officially on the transport vehicles coming into Maine, we received notification of that along with the tracking numbers. That occurred over the weekend, this past weekend. If that one weekend's experience was any guide, we'll hopefully have updates over the weekend as to when both the Pfizer vaccine as well as the Moderna vaccine, if it gets authorized, would be coming in. We are hoping for the early part of next week, but as of right now, Mal, we have not been given a firm timeline.
Is there anything that else you would say to people living in assisted living facilities who are now concerned that another week or even longer for a delay for a vaccine could literally mean life or death?
It's deeply concerning. We share that concern. There's no question about that. And we are hoping that once we get better insight from Operation Warp Speed as to what our allocations will be, we won't have to make these decisions, and we can activate that second part of the partnership as soon as possible. I am going to turn next to Joe Lawler at the Press Herald.
Yes, hello. Just a couple of quick questions. So I know you were, when we're talking about the Moderna vaccine, is the fact that there is a manufacturing facility in Portsmouth, New Hampshire, is that, would that have any effect on distribution of the vaccine to Maine?
Not that we've been told, Joe. From what we understand, is that even though there is that manufacturing facility, it is likely centralized and then shipped back out from there. So I'm not aware of any immediate benefit or faster delivery. It's possible. It's very possible, and one certainly we could hope for, but it's not been communicated to me that we would be receiving it sooner rather than later as a result of that physical proximity.
Okay, thanks. And then just to follow up, I noticed you mentioned briefly about the hospitalization rate kind of leveling off over the past week or 10 days or so. And do you have any indication of why that might be?
Well, the first observation, Joe, is that even though it has achieved a little bit of stability, as we've seen so many times, that could change. And so, although we hope it doesn't, it is a distinct possibility that hospitalizations could trend back upwards. One hypothesis, Joe, and given how fresh these data are, it's difficult to have concrete conclusions. But one hypothesis is that what we saw with respect to the peak in hospitalizations was an after effect of the most severe cases coming out of the Thanksgiving holiday. Those individuals having recovered, being discharged from the hospital, we've gone back to something of a steady state hospitalization. That is a very high steady state with over 170 people in, but it's not the result of a discrete event a series of discrete events like Thanksgiving gatherings that may have prompted that. The concern, and this ties back to the first thing I started with, Joe, is that as we go into more winter holidays next week, there's that possibility for more transmission leading to more hospitalizations in the 10 or 12 days after. And to round us out for the afternoon, I will turn things over to Allison Ross.
Hi, Dr. Shah. Thanks so much for taking my question. So some advocates for incarcerated people have called for them and staff to be moved up from phase 2 to phase 1B in this vaccination plan. Has this been considered? And if so, is there a rough timeline as to when they say staff or any incarcerated people might actually have access to this vaccine?
Sure, Allison. It has been considered. It is being considered. It will continue to be considered. No firm decision has been made, at least certainly as to where they may be in the phases. We understand the viewpoint, and in fact, just earlier in the week, I had the privilege of chatting with the Permanent Commission, where a number of the commissioners on that commission raised this view to me. I certainly understand where they're coming from. At this time, there hasn't been a final decision that's been made. And right now, Allison, we are just laser focused on getting vaccine out to hospitals. That's really where we're spending much of our focus right now. But we recognize that there are these very good and thoughtful questions that are out there with respect to individuals who are incarcerated, as well as other individuals who are in phase 1B, teachers, snowplow drivers, and others that are out there that we know are at risk. We're going to have there are going to be some very difficult and hard decisions that are in front of us with respect to all of these categories. As of right now, nothing has been finalized, but we know that those are discussions that are out there.
Great, thank you.
Thank you. Before we adjourn for the afternoon, I just wanted to recap where we are with respect to vaccines. By the time you are listening to this, well over 2,200 people in Maine have already been vaccinated against COVID-19, representing almost half of the first week's allotment that we received across the state. By the beginning of next week, we hope to receive even more vaccine and continue with that vaccination and perhaps even accelerate even more, moving into places like skilled nursing facilities. We know that this will be a monumental challenge that we have ahead of us, and there will undoubtedly be bumps in the road, some of which we've just talked about based on what we've experienced from Operation Warp Speed this week. But we thank you for bearing with us and asking good questions. We know that every single person out there has questions, if not concerns, about the vaccine. The one that I touched on today was an omnipresent concern that's been raised to us about whether the COVID-19 vaccines have been rushed. As we talked about, although they have been accelerated, they have not been rushed. They've met every marker, every goalpost, every mile marker they needed to in order to get to where they are. And rather than being a sign of having been rushed, what they are a sign of is what we can achieve when the scientific community, the business community, government, and other stakeholders comes together to solve a common problem. These vaccines represent a breakthrough and one that will ultimately be our way out of this tunnel. So I ask everyone to consider all the data as you are thinking about what's best for you and your family. But more than that, keep asking questions. If you keep asking questions, I pledge to keep providing open, scientific, truth-based answers to all of your questions in a respectful way. So with that, I hope everyone has a good weekend. As always, please be kind, take care of one another. We'll talk again on Monday.